I think this is a really exciting session that's been added to the conference. As dermatologists, we are uniquely positioned to be able to offer both medical management and procedural interventions to help our patients. Not many specialists have that opportunity. I have no relevant disclosures. So just to briefly review, systemic sclerosis, this is going to impact the skin. It starts in the distal extremities, can move more proximally, and it's functionally disabling, right? So you can see a positive fist sign, positive prayer sign. These patients have joint contractures. And facial involvement is very common for these patients. When there's sclerosis around the mouth, that leads to smaller mouth opening. And you can imagine that also is function disabling. And cosmetically, we do see increased perioral rhytids and thin lips, extremely bothersome to our patients. And certainly, we are not replacing medical management for scleroderma, right? So first line is mycophenolate for the skin. It's hands down the best treatment. It's beyond the scope of today's talk to review the other therapeutic options, but we're talking about potentially other immunosuppressive options or IV meds. But mycophenolate really does work well for scleroderma. So you can see before treatment that you're unable to pinch the back of the hand of the patient on the top left, and after initiating high doses of mycophenolate, skin laxity is normalizing, and even that positive prayer sign. It's not perfect, but there's a dramatic improvement after initiating mycophenolate, especially if you do it early on in disease course. However, medications can only take us so far. There are limitations in their efficacy. There are side effects that we have to consider. There's lab monitoring, and for our young patients, sometimes hours of IV infusions are just not an option. So to highlight the role of injectables in these patients, I want to start off with this case. So this is a woman who had scleroderma for numerous decades, and as well as lung disease, was actually doing fairly well on mycophenolate, 1 gram BID. It's a fair dose. And rheumatology had referred her to us in dermatology clinic because the perioral changes were really cumbersome. And she was actually a musician, so she felt like her singing quality had changed. And when you ask her what bothered her the most, actually she said that when she was a young woman, she was known for having this big Julia Roberts-like smile. And she was slowly noticing that that was worsening despite other areas improving. So she was really distressed. And things like biting into a hamburger or biting into an apple was something that she could no longer do. She had to cut up all of her food into small pieces. She was at the dentist for over an hour for a routine cleaning because of the difficulty getting to the back teeth. And a story like this is actually not that uncommon in our scleroderma patients. So if you were to ask a physician, what are you most worried about when it comes to skin manifestations, they're probably going to mention the hands, right? They're worried about the skin tightening of the hands, the fingertip ulcerations that we see in these patients. But if you ask a patient, you're going to get a different answer. They're most bothered by the perioral changes. So mouth furrows, thin lips, small mouth were the leading concerns for these patients. But when we took a look at our patient and examined her elsewhere, you can appreciate again that the skin laxity in the dorsal hands is actually very good. And yes, the fingers are indurated, but she has good functional ability. She can fully make a fist. So for a patient like this that's really bothered by the perioral changes, does it make sense to go up on immunosuppression or add an IV med? So introducing hyaluronidase. So I imagine everyone in this audience has hyaluronidase readily available in the office. If you inject hyaluronic acid fillers, you know that we have hyaluronidase available to undo the unwanted effects of fillers. And we know hyaluronidase breaks the bonds of hyaluronic acid. And mechanistically in scleroderma, it makes sense that hyaluronidase could be helpful because we know, especially in advanced disease, that hyaluronidase levels are too low. So by giving back this missing hyaluronidase, we're able to help with the fibrosis that we see in these patients. And to prove that, we had 4 patients with various connective tissue diseases that led to sclerosis, and we decided to inject hyaluronidase monthly. Prior to injection, we first started off with topical numbing, but hyaluronidase can be fairly painful, and we're injecting already a very sensitive area, so we did convert to nerve blocks in patients who they found the procedure a little bit more comfortable with a nerve block. And you can see the injection points on the right, the approximate injection points. So we diluted a vial of hyaluronidase 200 units and injected about 0.1 cc's in the injection points there. And this is that patient that I was describing for you. She had a 7 millimeter improvement at month 6, and that might seem kind of like a modest improvement, but you can see that her mild handicap and systemic sclerosis score dropped from 24 to 7. So she was saying around Valentine's Day, she was able to pucker her lips for the first time to kiss her husband in many years. She said that she'd forgotten she lost the ability to whistle. She was able to whistle again. She was enjoying her foods more, and she felt like she could confidently sing on stage again. So she was absolutely thrilled. You can see that improved smile on the right after treatment. And we were surprised. We were telling patients, don't expect dramatic differences in the perioral rhytids. I have a better case of that in a second, but that also began to soften. Here's a more dramatic improvement in the mouth opening capacity. This is just after 2 sessions. So just 2 vials of hyaluronidase. She had an improvement by 1.5 centimeters in her mouth opening. And then I want to bring your focus to that bottom row. I promise this patient did not get any filler, no botulinum toxin here. This is just hyaluronidase. And you can see that she's able to better relax her lips. And even her lips, they appear fuller in size. So overall, from this case series, we are recommending to do at least 3 to 4 monthly sessions. That seems to be when you can maximize your benefit. And overall, there were no serious adverse events. As you all know, hyaluronidase is a safe procedure to inject intradermally. Yes, there was temporary pain at the injection sites, but that was mitigated with the nerve blocks. And if you're injecting in the perioral region, you should expect bruising and swelling. So many of our systemic sclerosis patients also suffer from severe Raynaud's. And that is something that we see in various connective tissue diseases like lupus and dermatomyositis, for example. We know that the fingers turn red, white, and blue due to vasoconstriction in the cold, but it's not just a cosmetic concern. In severe and refractory cases, we will get painful ulcerations, and I have seen too many cases of people losing their fingertips due to severe Raynaud's. We'll see gangrene, for example. So in severe cases, we need to treat this condition aggressively. So this is my therapeutic algorithm for Raynaud's. Mild cases, behavioral modification is enough, but for moderate to severe cases, I don't rely on topicals. I'm jumping for an oral systemic from day 1. And I'm starting to use botulinum toxin earlier in my therapeutic algorithm because it works. We published this in 2021. We had several dozen patients that had scleroderma-associated Raynaud's, and you can see that 80% had a clinical benefit, and greater than 90% of patients that had ulcerations improved. So those are great numbers, dramatic numbers. And important to note, there were no serious adverse events. So theoretically, you could get some weakness of the hands, but I've yet to see it. And the digit that's most at risk are the thumbs. So if you have a concern, like we had a cellist, for example, that came in with Raynaud's and wanted the botulinum toxin, if you are concerned, you could exclude the thumbs. Thankfully, that is the digit that is the least spared, that is the most spared in terms of Raynaud's anyway. So if that digit is never involved, you could avoid that digit. But you can see here with botulinum toxin, we were able to preserve this fingertip. Ulceration has healed, and now we just have a pitted scar. And if you do nerve blocks of the fingers, you're following a very similar technique. We're injecting into the neurovascular bundle of the fingers that runs on the sides, right, the lateral fingers. And if you feel your hand, there's a little notch right above the MCP. That's where we're aiming for. You go to bone, you come off slightly if you're unsure where to go, and you're going to inject about 5 units of brand name Botox, but other botulinum toxins work just as well. You just convert the units as you need. So we're doing about 100 units per hand. And just to highlight how quickly botulinum toxin can work, I wanted to end with this case. So this was a young woman in her 30s. She was very high up in her company and developed this connective tissue disease. It's a classic example. I don't know if you guys know what it is. I'll show you her palms, and that might give it away. painful papules of the palms. This is MDA5-associated dermatomyositis. It's associated with vasculopathy, so it has a very similar mechanism as Raynaud's. And the cutaneous ulcerations are extremely painful and can be very deep. This poor woman came in tears. She had been very healthy until her dermatomyositis diagnosis, and the pain from her ulcerations made it difficult for her to work. She came in on 60 of pred, max dose of mycophenolate, and the ulcerations were only progressing, so she was extremely concerned. So this is a close-up of her ulceration. We added botulinum toxin, and this is in under 1 month. You can actually see that she didn't have a chance to get her nails done. The manicure is growing out. That's how fast that this can work, and you can see the ulceration is beginning to heal. So I hope I convinced you that you should consider injectables as part of your toolbox in treating connective tissue disease. And again, us dermatologists, we are the best specialists to manage CTD of the skin. Thanks so much.
Thank you. We actually used up all our time, but if there's any questions, I also love to call Dr. Sao, who's one of my mentors, and she's done a ton of creative things for systemic disorders. I don't know, do you have any other thoughts, parting thoughts for the audience?
No, you ladies are incredible. That was amazing.
Thank you.
Such great work to do. Never be afraid
Yeah.
to try something with caution, as you said, test sites and such,
Yeah.
because there's so many tools we have.
Right, right. We're lucky. We're lucky to have those options. Yeah.
It was outstanding presentation.
Thank you. Thank you, everybody.
Enjoy the conference.